In populations with the highest prevalence, about 1% of the people have IBD. Locally, we estimate that there are about 2,000 people living with ulcerative colitis, and we expect more patients to be diagnosed in the next few decades. It would be to have the best quality of life for as long as possible, that is to say, to live as you possibly could have lived without the condition, with minimal disruption to your daily routine. Patients will have different experience with their disease course over the years. Some patients do well for many years after an initial flare. Some have more disease flares with time. Some have episodes of flares and remission, and some never truly achieve good control. Some patients prefer to manage their UC without the use of medications, especially newly diagnosed younger patients who otherwise have been in perfect health. It is normal to feel this way, but realistically, most, if not all patients, will require some form of treatment to keep their disease under control. There is no cure for ulcerative colitis yet, so the next best thing is to keep the disease as quiescent as possible. In medical terms, we call this remission. There are different levels of remission: clinical remission, biochemical remission, and endoscopic remission. In clinical remission, patients feel well with normal bowel habits and absence of rectal bleeding. In biochemical remission, laboratory values such as calprotectin are normal. In endoscopic remission, the gut lining will look normal under colonoscopic examination without any bleeding or ulcers. We can divide treatment into two phases. The first phase is the induction phase, which is to get the inflammatory activity down as quickly as possible as the patient will be quite symptomatic. This might require the use of 5-aminosalicylates or 5-ASAs, steroids, or biologics. Steroids require special mention here, as they work very well but should not be used for more than a few months if possible, because they can cause osteoporosis, diabetes, cataracts, just to name a few conditions. Steroid-free remission thus is a major goal in IBD care. The second phase is the maintenance phase, when the inflammatory activity is low and we use medications to keep the patient well. Patients would use either 5-ASAs, immunomodulators such as azathioprine, and/or biologics. Some patients are uncomfortable with the use of such medications for a few main reasons. Number one, reliance on medication. Patients may feel like they have given up or end up on long-term medication to maintain their health. What is important is to not lose sight of the goals of treatment, which is to achieve a good quality of life with medical help. In reality, not all patients with UC respond perfectly to treatment. Some go through a few types of drugs before settling on one that suits them the best. In the future, we may have better tools to predict which medication works best for individual patients based on their biology, but we are not there yet. In short, it would be great if you're on a safe medication that has kept you well and should stay on it for as long as possible. Most of my patients on treatment do well and continue to do so. Second reason would be the side effects of medications. Most patients on these medications do not suffer from any side effects, and these drugs are approved based on good scientific data that support a favorable benefit-risk profile for most patients. There will be patients with side effects, but these are in the minority. Your healthcare provider would be able to support you through the use of medications with regular monitoring. The medications are divided broadly into medications for induction of remission and maintenance of remission, or both. There are two things to consider when choosing medications. The first would be the disease activity, and the second would be the expected course of disease. 5-aminosalicylates or 5-ASAs and sulfasalazine are used for induction and maintenance. Steroids are used for induction, azathioprine is used for maintenance. Biologics such as anti-TNFs, anti-integrins, and anti-IL-12/23 are used for both induction and maintenance. Small molecules such as JAK inhibitors are used for induction and maintenance. How we choose which medication to use depends on the degree of inflammation seen and the predicted course of disease. Severe activity and poor prognosis would usually mean using more potent medication to control the disease. However, it is good to know that about 70% of patients remain well with 5-ASAs.